Good evening, and welcome to Essential Conversations for Hepatocellular Carcinoma. My name is Riyad Salem, and I'm thrilled to be joined by Mark Yarchoan from Johns Hopkins. Thank you to PeerView for providing this session and AstraZeneca for providing this educational grant for the webcast. If you haven't already done so, please complete the pre-event survey. A reminder, look out for additional follow-up polling during the presentation. We've also prepared practice aids that summarize many of the newer developments in care for HCC that can be useful when developing collaborative team-based treatment plans. So please download these resources before we get started. Finally, submit your questions throughout this evening's program using the live chat feature, and Mark and I will address them during the presentation. We'll also have some further discussion on your questions during the Q&A. Visit us at peerview.com/HCC virtual. So our goals for tonight are to provide you with updates on the evidence supporting immunotherapy-based platforms in HCC, including in advanced and intermediate disease settings. We want to offer guidance on integrating immunotherapy platforms into the team-based multidisciplinary management of intermediate and advanced HCC. And finally, we want to equip you to address practical safety, care consideration, and therapy delivery considerations when treating HCC patients using a variety of treatment modalities. So let's start with the scope of the problem. Despite advances in treatment and diagnosis, HCC mortality in the United States is increasing. And as you can see here from a report from 2 years ago, these continue to increase. The death rate in HCC continues to increase. If you project about 7 to 10 years, irrespective of the category, death rates continue to increase, with the exception of the Asian patient population. In reality, the basis of this presentation and the discussion tonight is that modern HCC care is a multidisciplinary, dynamic, and very collaborative relationship and process. The tumor board, the discussion with all the team members is really essential in improving patient outcomes. And here you can see from a report from our group that shows that the HCC patient is managed and discussed by multiple modalities, including oncology, hepatology, surgery, radiology. And from that discussion, the patient migrates from treatment to treatment and specialty to specialty to optimize long-term outcomes. One of the major advancements over the last 20 years has been the characterization of HCC in the cirrhotic liver by using the BCLC staging system. And by providing prognostic factors like tumor burden, like liver function, like performance status, patients can be categorized into categories that essentially give you long-term outcomes. And looking at characteristics, you start to identify the first best treatment option. In brief, very early patients are treated with potentially curative options like ablation or resection or transplantation. Moving on to the more intermediate stage now, this is where patients are now categorized into three areas. Some that can be treated with downstaging categories, with local regional therapies, and some that are approaching the advanced patient population that are best treated with systemic therapies. And of course, the area of most rapid advancement over the last 10 years is in systemic therapies for the advanced patient setting, and this is something that Mark and I will be discussing tonight. New to the algorithm this year is the individualized patient care concept, where while looking at the best first treatment option is the way to go, individualized patient decision-making as a team, as a group, as a collaborative multidisciplinary setting is how patient decision-making is ultimately made. And you can see here the addition of clinical decision-making in the BCLC schema, where now in the early setting, local regional therapies like chemoembolization or radioembolization have been added, with treatment migration, of course. And then, of course, the area of most advancement in the last 10 years in the advanced settings, things that Mark will be discussing a little bit later on, the immunotherapies, the tyrosine kinase inhibitors, etc., those treatments that are now used in first and second and even third line settings. Despite these advancements, there still needs to be more work. And many patients, in fact, go untreated. One report a few years ago talked about nearly 600 patients, with almost 50% of patients not receiving any active first-line therapy. Now, there could be a lot of reasons for this, but information and knowledge could be one of them. There are also patients in the more earlier settings, that is intermediate and early advanced patients, that were also reported to also receive no active treatment when first diagnosed. So this is a problem. Education is important, knowledge of this disease condition is important, and the usual trope that HCC patients don't do well is no longer true. The last 20 years or so have shown significant advancement in HCC, and these statistics are no longer acceptable given the treatment options that Mark and I and others currently have. And finally, as I mentioned before, everything is based and centered on the multidisciplinary team for management of HCC. The medical oncologist, the hepatologist, the pathologist, the interventional radiologist, transplant surgeons, the nursing staff. All of these patients are essential, and there have been a lot of studies that have published that have shown that when these teams work together, survival improves, and the best option is selected for the patient at the right time. And this is something that has been shown over and over in multiple settings to improve overall survival. So let's now shift over and start talking about collaborative strategies for innovative immunotherapy approaches combined with local regional therapies in patients with local disease. So Mark, I'd like to bring you in now and start talking about patient Greg. Greg is a patient with intermediate HCC. He's 62 years of age and presents to your clinic with Barcelona Clinic B, intermediate stage HCC. He's got good liver functions. His performance status is good, 0. He's got multifocal disease, as you can see on the scan on the right-hand side. One lesion's about 5 centimeters, one's about 4, one's about 3. And he wants to explore aggressive treatments. He wants to do the best thing possible. What are your thoughts on this case, Mark?
Yeah, I think intermediate stage HCC is very heterogeneous. And right now, I think there are big discussions about which patients should receive local regional therapy versus which patients should receive systemic therapy. And this is a goalpost that's sort of been evolving over time. But I think, what you're discussing is the new concept of, is there a role for combination approaches where we combine local regional therapy with systemic therapy? That's not a standard approach right now, but something that is being studied on clinical trials. And, I think a patient like this who wants to be aggressive, this is a young patient with preserved liver function. I think it certainly would be reasonable to offer a sort of combination approach of both systemic therapy and local regional therapy as part of a clinical trial. And certainly that's something we would like to do here.
So just to ask a couple of questions. So local regional therapy in the BCLC-B setting includes certainly chemoembolization as the gold standard. So is that something you might consider, Mark? Or would you try to enroll them in a clinical trial combining this TACE or Y90 or whatever with an immunotherapy? And so that is something that I'd like to ask. And then ultimately, I think something that comes up a lot is, what if this person has slight hepatic dysfunction? Say Child-Pugh B7, for example. What's your thinking along if that's the scenario you're confronted with?
Yeah, I think the second part of the question is easier to address. Patients with HCC, as you've mentioned, really have two problems. They have a sick liver, and then they have HCC that comes out of that cirrhotic liver, and so they really do have two competing causes of mortality. And so, whenever we see a patient with HCC, we always need to balance, the tumor control aspect and the cirrhosis aspect, and particularly for a patient who has very borderline sort of liver function. A lot of the procedures that we're talking about or therapies we're talking about can really push patients over the edge into liver dysfunction and make their life shorter rather than longer. So for a patient who's really borderline like this, that's a patient where I would be particularly nervous about not only local regional therapies, but also some of the systemic options that we'll be talking about. And so that's a patient where, there may be consideration for immunotherapy alone, where we have some safety data, at least for anti-PD-1 therapy with nivolumab. There's some safety data for tyrosine kinase inhibitors for patients with sort of borderline cirrhosis. So, those are options that we might skew towards in that sort of population. I don't know if you have thoughts about TACE unsuitability and where you draw the line for a patient who's a little bit borderline in terms of their liver function.
Yeah, we're going to talk about that a little bit later on in terms of what TACE unsuitability is. But one of the things that's certainly evolved, Mark, is the notion of selective treatment. No matter the local regional therapy, you have to be very selective because, as you mentioned, they have two conditions, the HCC and cirrhosis and hepatic dysfunction. So we have to make sure that we limit any potential non-target exposure. So if this is not something that I can do and I cannot be selective, I will certainly defer to someone like yourself and consider systemic therapy because of the benefits that we've demonstrated in that patient population. I just want to close off this case here, and at least in assuming he was Child-Pugh A, there's some work that's been done, certainly by many groups, but our group, we looking at Y90 compared to chemoembolization, and we did a small randomized trial that showed that if TTP is what you're looking for, Y90 appears to outperform chemoembolization, and that is something that's relevant in the transplant setting. And so in this patient population, certainly chemoembolization is reasonable. I think Y90 is also reasonable, but this is probably a discussion where local expertise, makes a lot of sense. Mark, I'd like to invite you to start talking about the rationale now for combining these types of approaches, the local, regional, and the systemic therapies.
Yeah, I mean, I think there's both a clinical rationale and then a biological rationale. The clinical rationale is that local regional therapy and systemic therapy really address different issues, right? The systemic therapy theoretically addresses extrahepatic disease, micrometastatic disease, may prevent new lesions from developing. And local regional therapy addresses the areas of greater concern where you have large tumor burden that you need to address. So there may be some sort of clinical synergy. The biological synergy is that local regional therapies can cause an immunologic cell death. Tumors die, and that can be picked up from the immune system. So it's almost like you're creating a vaccine within the patient's own body. Um, and so there are reasons to think that these approaches may not only be complementary, but potentially even synergistic in some cases. The final reason is that there was a time where patients would receive lots and lots of local therapy, and then eventually their liver function would decline, and they could actually miss the opportunity to receive some of the newer systemic therapies that we have. And one of the feelings that many have is that if you use systemic therapy earlier in the treatment course, you can really prevent that phenomena from occurring, get patients on effective systemic therapy earlier, and so that they receive more of the benefit of systemic therapy. So one of the things that we've been talking a lot about is how the intermediate stage has evolved. And right now there are a number of trials that I think are defining exactly what the role is of systemic therapy in intermediate stage disease. There are trials of local regional approaches with and without the addition of systemic therapy, as well as trials of systemic therapy versus local regional therapy. And I think these trials will be very important to define exactly where these treatments belong. I'll just note that there are plenty of trials that have been done of local regional therapies with and without TKIs. And in general, those trials have failed to show an overall survival benefit of early introduction of TKIs. But we now have more effective systemic therapy, and immunotherapy works differently. It works very well for micrometastatic disease. And so there's a biological reason to think that the outcomes may be different for these ongoing trials here. And I'll just add that in the old days, patients would move very linearly from local regional therapy to systemic therapy. But I think more and more, those of us who spend our lives treating this cancer understand that these cancers are much better treated in a multidisciplinary fashion. And there's more of a back and forth between local regional therapy and systemic therapy. So increasingly, there's data that patients who access systemic therapy earlier may do better. But also there's an increasing body of literature supporting the use of local regional therapy in more advanced stages of disease, including in the setting of local progression while patients are on immunotherapy, as well as patients with really critical tumors that need to be addressed local regionally. For example, patients with large portal vein thromboses. And I think that increasingly we appreciate that intermediate stage disease is very heterogeneous, and there are patients who should be treated with local regional therapy alone, systemic therapy alone, and then some patients who perhaps, at least on clinical trials, may benefit from the combination. Different criteria have been established for who might benefit more from systemic therapy. or more from local regional therapy. And one of the criteria that's been proposed is a criteria called up to 7 criteria, which is essentially you add the number of lesions with the diameter of the largest lesion. Um, Although I have to say that I don't ascribe to this exact cutoff in my own clinical practice. And I don't know, Ria, do you follow this in your practice?
Yeah, we don't, Mark. I mean, I think we're with you here. We still need to see a bit more evidence on that. There's a lot of these patients that could be downstaged, could be resected, could be benefited in different ways. So we look at this, but it's certainly not something that we've adopted in terms of decision making.
Yeah, I agree with you. I think every case is unique, and really these cases should be seen in a multidisciplinary fashion. So moving on here, this is a retrospective trial that was done that looked at the idea of which patients might benefit more from systemic therapy versus TACE. This was done in an era where patients were receiving TKI therapy. Again, now we're using more effective systemic therapy, so I think it remains unclear whether this would look the same with our contemporary systemic therapies. But this trial proposed that perhaps patients who have this beyond up to 7 criteria may benefit more from lenvatinib than from TACE. But again, I think we really do need prospective trials to define exactly which patients should get systemic versus local regional versus the combination. And I think particularly interesting are these trials that are trying to compare systemic therapy head to head with TACE. I certainly am not someone who thinks that local regional therapy is going away. But it may be something that we use more selectively and perhaps is used more in the setting of in combination with systemic therapy or in the setting of progression. And then this is just something I alluded to earlier, but there have been many trials that have been done that have looked at local regional approaches with or without systemic therapy in an era where the systemic therapy was TKI therapy. And I think what you can see here is that overall these trials showed that perhaps earlier introduction of TKI therapy can prolong progression-free survival, but none of these trials conclusively showed any benefit with regard to overall survival, which is why most of us would not use a TKI in this setting, in the intermediate stage setting. But again, it's quite unclear whether our immunotherapy-based therapies would have an overall survival in this setting, and so I think that remains to be seen. This is the idea of perhaps the next wave where we may be headed is the idea of combining local regional therapy with systemic therapy, not only taking advantage of the potential clinical synergy where the local regional therapy addresses the most critical area of the tumor, because again, most of these patients get into trouble when they have progression in critical sites like in their liver, which can be effectively addressed with local regional therapy. But also this idea that the local regional therapy could actually stimulate a tumor response against specific tumor neoantigens. This is something that's been shown in many mouse models. The idea that if you add local regional therapy, you enhance immune responses to checkpoint inhibitors through something called an abscopal effect. I think this has been quite difficult to demonstrate in human patients. It's something we talk a lot about. I think many of us believe that there's something here, but it's been hard to show, I think, clinically, although something that we continue to look for as an explanation for why these therapies could be combined.
Mark, I just wanted to add, if that's okay here, there's obviously tremendous excitement to the idea of that internal vaccine, like you mentioned. At least from my perspective in interventional radiology, we're excited at the prospect of either embolization or radioembolization or ablation or cryoablation. All of these things representing tools that we could use to stimulate that immune system. So all of that stuff. So there's really a lot of opportunity here for research and advancement, and to really benefit the patient population depending on their presentation.
I completely agree with you. So this is something we've alluded to several times on the program, but there are many ongoing clinical trials that I think will potentially redefine how we use local regional therapy and systemic therapy in the intermediate stage. This is one such trial, the DEMAND trial, which is randomizing patients to bevacizumab and atezolizumab with or without local regional therapy. And the primary endpoint is survival. But we also have trials that are looking at TACE alone, which of course is the current standard of care for the majority of patients in the intermediate stage, with or without concurrent immunotherapy, in this case, durvalumab or durvalumab with bevacizumab. And so this is perhaps looking at the other side of the equation, which is adding systemic therapy earlier beneficial. And then there are other trials ongoing. This is a trial of everybody gets local regional therapy, but with or without systemic therapy. In this case, durva-tremi, so a CTLA-4 inhibitor plus a PD-L1 versus durva-tremi plus lenvatinib, which is a multi-tyrosine kinase inhibitor, quite intensive triplet immunotherapy. So many different trials ongoing. This is not all the trials, but I think just gives a sense that there are trials of local regional therapy with and without systemic therapy versus local regional therapy, and systemic therapy with or without local regional therapy. So many different trials ongoing, trying to get at the heterogeneity of intermediate stage disease and potentially which patients could benefit from which modality or modalities in combination. Getting back to the rationale for local regional therapy and immunotherapy, I think there's an increasing body of preclinical evidence that suggests that these approaches can be combined and are at least complementary and potentially even synergistic. I guess the question is for you, Riyadh, is just um, you know how would you describe the current state of clinical evidence, and do you at least feel that these combinations are safe even as we're waiting for clinical outcome data from these larger trials? And what's been your experience with this?
Yeah, Mark. I mean, the reality is, we're always waiting for, clinical evidence, the highest evidence we can get. But sometimes, these take a long time to complete. And in the meantime, we have hundreds of patients to treat over several years. So
Yeah.
we have to take the best evidence we have at the time to make some clinical decisions. And I would tell you that, for the longest time, we were always worried about what happens when you combine an LRT with certain systemic therapies, et cetera. And by and large, they've demonstrated to be safe off trial now. This is just in clinical practice. And now more and more, certainly with our medical oncologists, we are performing the LRT that's indicated for the patient. And then, a month or a few weeks later, they start on some type of systemic therapy. So to capitalize on the cytotoxic effect of the LRT and to capitalize on the TTP and the PFS and the OS benefit of the immunotherapy, to capitalize on the vaccine effect you described. So we are not seeing any toxicities that make us change that practice. Yes, of course, we're waiting for the highest level evidence and we're anxious for the results. But in practice, in clinical decision making, there's no doubt that we've adopted these combinations because we've demonstrated them to be safe. And in fact, we've done that. And just to complete the bottom of this comment here, Mark, is that work, that combination, the collaboration, has spanned now the entire BCLC spectrum. We get biopsies now for NGS, et cetera. We do response assessment now, immune response assessment, mRECIST assessment. So that collaboration continues to expand, but it's really based on the fact that we can do these things, and they are certainly have been shown to be safe. Is that your observation?
Yeah, no, completely. We're lucky that we have clinical trials to offer patients where they get combination approaches. But if patients are not candidates for clinical trials or don't want to participate in clinical trials, and they really do have a critical situation where they have metastatic disease, but impending issues in their liver, I certainly, after long discussions with patients, would offer this in select cases. And I think that there is enough evidence now that these combinations appear to be safe. And in select cases, it's something I would even consider off of a trial. I agree with you. Maybe we could just get into the weeds for a minute. And you're lucky to offer many different local regional approaches. You can do TACE, ablation, cryo, uh, Y90. Are any of these approaches, you think, superior in their ability to promote an abscopal effect with immunotherapy? What are your thoughts about this?
Boy, that's a great question. I know was always a lot of initial enthusiasm on the ability of cryo to incite that immunologic effect. There certainly has been some recent data showing that radiotherapy certainly can play that role as well. Certainly, ablative radiotherapy as well. So quantifying which one is better able to, I'm not sure I have an opinion at this point, but certainly that all of them or most of them are to some degree able to incite that effect, and maybe that's all you need. It's just to get the ball rolling, and it's not really the magnitude is not dependent on that initial insult. So I don't know that I can tell that one is more effective than the other, but certainly there's a lot of excitement with all those modalities. But let's take a look at another case, Mark. You up for another case? Let's do it. So this is Phoebe. Phoebe is a 58-year-old female with BCLC-A disease. So she has early disease, but it's a solitary large tumor, which is BCLC-A. Note for the viewers that BCLC-A does not have a size, for solitary lesions, does not have a size limit. So technically any lesion that's solitary is a BCLC-A. In reality, however, when you start getting to 10, 12, 14 centimeter tumors, you have microsatellites, so it's not solitary anymore, but just something to think about. Phoebe's got good liver function, good performance status. Now, she's non-cirrhotic, Mark, so a little bit different. The BCLC algorithm is based on cirrhotics, but she's got an alpha-fetoprotein of over 5,000. And so the first thing I'd ask of you is how you'd manage this patient. Are you concerned about the alpha-fetoprotein? And anything in terms of adjuvant immunotherapy you'd consider?
Yeah, I have a lot to say in this case. I mean, this is a patient who, as you said, should be offered potentially curative therapy. But we know that the chance of recurrence here is very high, 70% or more in some series. The large tumor size, the high AFP certainly put this patient at higher risk of recurrence. Right now the standard of care would be to do resection alone. But there's not a single other tumor I can think about where we have highly effective systemic therapy where we're not using those systemic therapies to cure patients. And so, I feel very strongly that in the future, we'll find a way to use our systemic therapies to cure patients. I'll just note there are several clinical trials that are ongoing of adjuvant immunotherapy. Um, there was a press release very recently that the addition of bevacizumab and atezolizumab in the adjuvant setting prolonged disease-free survival for resectable HCC. We have not seen those data yet, so this is not something that is a standard recommendation yet, but I think it's a sign of what's likely to come in the near future. I think one of the big questions in our field is, do we give immunotherapy after surgery or do we give it before surgery, neoadjuvantly? And there are a lot of trials of neoadjuvant immunotherapy as well in our field. And the data for that are, at least in melanoma, there's data if you give immunotherapy before surgery, you do seem to have a better effect with a significant decrease in disease-free or in disease recurrence, giving the same number of immunotherapy doses, but just shifting by 2 months so that patients get 2 doses before surgery. I think that's something that needs to be explored in HCC on trials.
So I think we both agree, Mark. Probably hepatic resection is the first thing you'd offer her curative therapy. I would agree. So let's talk a little bit about hepatic resection. In general, when you think about hepatic resection, there are guidelines that provide us information on the surgical guidelines in terms of who's a good candidate for resection. Single nodules, of course, irrespective of size, if you can perform that resection with adequate future liver remnant and without clinically significant portal hypertension. And that's defined as a hepatic venous portal gradient of over 10 millimeters of mercury. The other issue has to do with the presence of varices and thrombocytopenia and large platelets. So if you've got portal hypertension, this becomes a bit of a challenge. But in this case, in Phoebe's case, she does not have portal hypertension. She's got good liver function. And again, this is well within the guidelines. But as you mentioned, resection is curative, but has a high recurrence rate. So this is the issue. And potentially that alpha-fetoprotein that was over 5,000 might be a bit of an issue for Phoebe. In terms of future liver remnant, that just defines the amount of liver that's left behind. And when you do the math, in general, when you have a normal liver, no portal hypertension, you need about 20% left for to maintain liver function and life, of course. And when you're cirrhotic, you need more because there's intrinsic hepatic dysfunction, and so 40% with cirrhosis. But again, we have a recurrence problem where it's about 70% at 5 years. And again, look, thinking about what that means, it obviously depends on the baseline characteristics. So the more nodules you have, the higher the likelihood of recurrence. And this is data that was presented a long time ago. The larger the tumors, the higher the likelihood of recurrence. The more complex the surgery, etc. And of course, whether you have margin or not. If you have a tumor full margin, then you're going to have a higher rate of recurrence. So this was studied in STORM several years ago. The idea that you could perform a curative therapy, either resection or ablation, and then treat with sorafenib. And that study failed to improve recurrence-free survival. This is in contradistinction to what you just mentioned, IMbrave 050, that was just where we haven't seen the data, but at least the announcement was made that it was successful in extending recurrence-free survival. So I think we agree that resection is the best option for Phoebe. Obviously, what the pathologists identify at explant is going to be important, and the tumor microenvironment is very important. If I can have you, Mark, to tell us a little bit about the tumor microenvironment in HCC.
Well, before we start splitting, let's lump and just talk about HCC in general. So HCC is a relatively immune-resistant tumor type. The response rate to single-agent PD-1 or PD-L1 is in a range of about 15%, which is quite a bit lower than, the sort of more inflamed tumor types like lung cancer or melanoma. Some of that is because HCC has a fairly modest tumor mutation burden. So we know that the more mutations a cancer has, the more abnormal proteins the immune system can recognize and attack. And so that has something to do with the response rate to anti-PD-1 or anti-PD-L1. Some of this has to do with just the liver itself likely being an immune-resistant tumor microenvironment. We know that other tumor types that are metastatic, we tend to see the liver mets respond better than the lung mets respond better than the liver mets. So there's something about that liver milieu that also probably confers some immune resistance. Now, within HCCs, we know that some HCCs are more immune inflamed than other HCCs. Exactly why that is unclear. Some of it may have to do with tumor genetics. There's at least some research suggesting Wnt beta-catenin mutations conferring some immune resistance, although that hasn't panned out in other prospective studies. We know that PD-L1 expression is somewhat rare in HCC compared to other tumor types, and we see responses in PD-1 positive and negative HCCs. So I think this is something that we need more research in, but I think overall HCC is a fairly immune-resistant tumor. And then this was mentioned, this is the IMbrave 50 study looking at adjuvant atezo-bev in patients who are at high risk of recurrence after resection for HCC. And again, there's just a press release that this trial met its primary endpoint, but we haven't seen the data. I think this, until we see the data, some of the obvious questions are, this is the combination of atezo-bev adjuvantly. The question is, do you really need the bevacizumab, or is this all the atezolizumab? We know that bevacizumab doesn't seem to have activity in the adjuvant setting in other tumor types. So it's unclear when you give two drugs which one is really conferring the positive benefit. So there is a trial of adjuvant durva-bev, and in this trial is randomized, so it's durvalumab with or without bevacizumab. And I think this trial will really answer, is checkpoint inhibitor alone what we need, or do we really need the combination with bev? So time will tell. I think this is also a very important study that I look forward to. One thing to know is the IMbrave 50 study, that's the bev-atezo study, had a somewhat higher risk population, patients with multifocal disease or macrovascular invasion. Emerald 2 has perhaps a less high risk of recurrence population. So there will be differences in the patient populations between these studies, and it'll be interesting to see whether it's only the highest risk patients who benefit or whether this is really across the board that this is something patients should get. Again, we haven't talked much about transplant, but we know that that liver transplant is a great option for a subset of patients because you cure not only their HCC but also their underlying cirrhosis. Unfortunately, we don't have enough livers for everybody, so we have strict criteria for who can be a liver transplant candidate. And Riyad, anything you'd want to add here?
Yeah, I mean, I think one of the evolving narratives in the transplantation setting is the use of IOs in a patient that may potentially go on to liver transplantation. What are your thoughts on that? Because that would be something you would do, and then that patient will come back to our tumor board to see whether we transplant. But what are your thoughts on that? What are you guys doing at Hopkins?
Yeah, I mean, I think there's good data that patients who already have a liver transplant, you really generally don't want to give an immune checkpoint inhibitor because the rate of rejection is unacceptably high. I think the converse is more complicated. So if you have a patient who is on systemic checkpoint inhibitor therapy, has a great response, is downstaged, and is now a transplant candidate, do you feel comfortable giving them a new liver after they've received immunotherapy? Especially because the half-life of these drugs is very long, a month or more in some cases. I think the available data, the largest series being from Mount Sinai, suggests if you wait about 3 months from the last dose of checkpoint inhibitor, in most cases you can get away with giving a liver transplant without much rejection. But this is a small series, very little data, and something we certainly do, but cautiously.
Yeah, certainly there are forces that sort of make us perform certainly LRTs in that patient population, but also we've seen a lot of examples where potentially the systemic therapy might downstage that patient as well. So there is some interest in that. Sometimes access to the local regional therapy is limited. The blood supply may be challenging. For me, yes, of course, I can do LRTs, but I need a blood supply that goes to a lesion. So there are technical challenges that exist with some LRTs, and that opens up that possibility of, well, what about a systemic therapy that might potentially, be used in that downstaging setting? I know there's some work that's been done with Emrysys to try to downstage using systemic therapy. I still think that data is relatively immature, but it's certainly an interesting concept to look at.
Yeah, and this is going to be studied prospectively, actually. So there's a trial of durvalumab and tremelimumab, again, a single dose of a CTLA-4 inhibitor plus a PD-L1 inhibitor prior to liver transplant. In this trial, they're giving a 72-day washout from the last dose of immunotherapy because, again, the concerns of the long half-life of the checkpoint inhibitor, and at least with a couple of half-life here, perhaps the risk of rejection will go down. So this should really answer the question in a prospective way.
So maybe, Mark, we can talk a little bit now about transitions. And this is an important topic, certainly for the listeners and in general for us as practitioners, is, as you mentioned before, historically it's been pretty linear. We do LRTs until pretty much there's hepatic dysfunction. There are a few treatments available. But now with the advent of a lot of treatments, myself and other practitioners that perform LRTs, one of the things we have to be cognizant of is liver function, and to permit the proper transition of the patient from an LRT to a systemic therapy to allow that patient to benefit from these treatments. There are too many good treatments available now that this has become sort of top of our list now when we perform local regional therapies. And so when you think about this patient here, so let's take a look at another patient here, Mark, and interested in your input. So this is a patient. David is 66 years of age. He received a TACE for local regional disease. And you asked me a little bit earlier on about incompatibility or unsuitability of embolization. I'll get to that in a second. But basically, he progressed on chemoembolization, now developed lung nodules. I think he had an elevated AFP, which is predictive of him developing metastases. But certainly when you think about patients that are unsuitable or refractory, there are certainly a lot of organizations that have looked at this. And why? Because it's important to have some sort of guidance, some sort of guidelines to help the practitioner know when to go from one modality to the other. And not everybody's going to have a tumor board, not everybody's going to have a mark or a RIAD on site to help with that. And as a result, some guidelines are appropriate. And certainly things like a couple of treatments that proved ineffective without response, etc., is something to consider as taste refractory or taste ineffective. The inability to get to the vessel because of parasitization or non-target deposition, you'll deposit in areas other than the tumor and maybe risk too much liver injury. And there are also some conditions that are quote unlikely to respond. Diffuse multifocal bilobar disease. That's not going to respond to any type of local regional therapy. But certainly that's something that we've been thinking about in this patient population. So Mark, getting back to you in terms of David's option now, I taste him. I did my job. I thought I did a good job, but not good enough because he's now developed lung metastases. What are your thoughts now in terms of systemic therapy? I transferred him and sent him your way. He's still Child-Pugh A. I was very careful of that stuff. So he's got good liver function and good performance status. So what are you thinking in your clinic for David?
Well, first of all, I think it's helpful to loop back to the idea of combination therapy because, those lung lesions are not a failure of your taste. They were probably there before you taste this patient. And these are the sorts of patients that make you wonder, should we be using systemic therapy earlier to address that sort of micrometastatic disease? But that's a side note. So this patient has now advanced stage HCC. At this point, I think there's no question that they would benefit from systemic therapy. We really have two regimens that prolong life compared to our old standard of care sorafenib, and that's the combination of atezolizumab, bevacizumab, or durvalumab and tremelimumab. A CTLA-4 PD-L1 combination for durva-tremi. Again, both of these regimens have overall survival benefits over our old standard of care sorafenib. They've never been compared head to head. And so, for a patient like this with fairly aggressive disease, progressing pretty quickly, this is a case that I might lean more towards atezo-bev just based on those characteristics. But, I think both atezo-bev and durva-tremi are certainly reasonable, appropriate recommendations. And again, although we've gravitated more towards our contemporary immunotherapy-based regimens, there are still patients who get TKIs in first line, such as patients who have contraindications to checkpoint inhibitors, patients with active autoimmune disease or liver transplant, something we've talked about already. So a lot of options, exciting time to be treating HCC, much more exciting to be a medical oncologist than when I started, when we all had just sorafenib. Just to fast forward here, this lists the evolving treatment landscape, and you can see here these are some of our systemic options on the right. So I think in general, patients who are candidates for immunotherapy should be treated with atezo-bev or durva-tremi in front line. I think many of us continue to use atezo-bev as a preferred option, especially because of the high response rate and PFS. I think durva-tremi is a great option if a patient has a lower burden of disease where what you really care about is that tail on the curve. If they respond for a really long time. And the tail on the curve on durva-tremi is quite impressive. And then I think we really have no data for anything after atezo-bev or durva-tremi. I think most of us would reach for a TKI in second line. And this algorithm suggests a first-line TKI like sorafenib or lenvatinib. I also think a sort of traditional second-line TKI like cabozantinib is quite reasonable after bev-atezo or durva-tremi. Again, we just don't really have data. And for me, after someone comes off of durva-tremi, I would probably reach more for a first-line TKI because they're really VEGF naive. A patient coming off of bev-atezo, I think a second-line TKI is very reasonable. And for all these stages, again, clinical trials are always a great option. Again, it's amazing how much progress we've made in the last couple of years, and I'd like to think that some of our clinical trials are as much of a quantum leap forward as what we've accomplished in the last couple of years. So this is data from the IMbrave 150 study. This is the study that established bevacizumab and atezolizumab as being a preferred first-line therapy for patients. And what you can see here is that the combination of atezo-bev resulted in not only longer PFS, as is shown on the right, but also longer overall survival, as shown on the left. The median overall survival in this study was 19.2 months. Interestingly, the sorafenib also performed quite well, 13.4 months, much better than we saw in older trials, probably reflecting just how our care has gotten better overall for HCC. And just to look at other secondary endpoints, so you can see the response rate for atezo-bev is up to 30%, much better than the sorafenib at 11%. And for the first time, we're starting to see some patients with complete responses, which is, again, extremely exciting, 8% of patients achieving complete responses. I have patients alive today on atezo-bev or just on watchful waiting who got atezo-bev on the clinical trial of IMbrave 150, which is just amazing. In oncology, we often have this trade-off where we have therapies that are more effective, but unfortunately also more toxic. In this case, atezo-bev was not only more effective, but also in general better tolerated than the sorafenib. So there was actually quality of life metrics, and the quality of life was better for atezo-bev than sorafenib. And that's in part because patients didn't get the sort of diarrhea, hand-foot syndrome that patients get with TKIs like sorafenib. The one side effect that I think is worth devoting a little time to is the bleeding issue. Bevacizumab was developed as a single agent for HCC years ago, but that development was stopped because of an unacceptable risk of bleeding with bevacizumab. And so when bevacizumab was resurrected in combination with atezolizumab for HCC, there was really a lot of attention to try to select patients who wouldn't bleed with bevatezo. So all of these patients underwent a screening endoscopy before going on the trial. And varices had to be treated according to local standards of care before patients could go on the trial. And in spite of that requirement, there was at least some numeric imbalance, with 7% of patients bleeding with bevacizumab in the trial, and a couple of even fatal bleeds with bevacizumab. So, I think that patients who've had recent bleeds, recent strokes, these are patients who probably shouldn't get bevatezo and should be using a different first-line regimen such as durva/tremi. And in general, the FDA label says that all these patients should undergo screening for varices within 6 months of starting atezo-bev. And then, the other frontline regimen that I think is worth discussing is the combination of durvalumab and tremelimumab. Durvalumab is similar to the atezolizumab. It's a PD-L1 inhibitor. And tremelimumab is a CTLA-4 inhibitor similar to ipilimumab. It's a drug that primarily works on CD4 T cells and is involved in priming an immune response. And in this study that we're going to discuss, the Himalaya trial, this was a trial of sorafenib versus PD-L1 alone versus the combination of PD-L1 plus CTLA-4. And the primary endpoint was overall survival. There was another arm of the study with a different dosing regimen that was closed early, so really just 3 arms moved forward. And this is the overall takeaway. So the combination of durva/tremi showed statistically significant improvement in overall survival versus sorafenib. And you can see that the durvalumab by itself didn't quite meet statistical superiority over sorafenib, but did show non-inferiority. And just to show some of the takeaways here, you can see that the addition of CTLA-4 does modestly appear to increase the response rate to 20% from 17% for durvalumab alone. But I think where you really see the curve separate, and I'm going to go back, is in the tail of the curve. And you can see, looking out at 36 months, there do appear to be more patients who are controlled on the durva/tremi arm than just the durvalumab arm. And this is something that makes sense looking at the mechanism of action here. So just to fast forward in terms of adverse events, so when you add in durva/tremi, so when you add that tremelimumab, you do see more immune-related adverse events, with about 13% of patients having severe immune-related adverse events versus about 6% for the durvalumab. So it does add a little bit of toxicity. but overall fairly well tolerated. Um, and then I just want to quickly touch upon the other dual checkpoint combination. Nivolumab and ipilimumab is approved in the second line in HCC after prior sorafenib. This was a trial done at a time when all we had was sorafenib in the frontline setting. And there is an ongoing trial of Nivo-Ipi in frontline, the Checkmate 9DW study. And so it's possible that in the future we'll have more than one checkpoint inhibitor option alone in the frontline setting. So just to fast forward here a little bit, what are my take homes for first line HCC? So in the advanced setting, we now have two regimens that improve survival over TKI therapy, and that's atezo-bev or durva-tremi. And so these are the two preferred regimens. How do you choose between them? Atezo-bev appears to have a higher response rate, appears to have better PFS, but does have side effects, including bleeding, that make it an unacceptable regimen for a lot of patients. And so patients who have varices or a particular high risk of bleeding should get durva-tremi instead of bev-atezo. And then I think there are still patients who are candidates for single agent PD-1 or PD-L1. This is something I would consider for patients who really are borderline for therapy, have sort of Child-Pugh B HCC where you're particularly nervous about side effects, where perhaps a single agent PD-1 or PD-L1 would be reasonable to consider. And then I do think that TKIs continue to play an important role in the frontline setting for patients who can't get checkpoint inhibitors for whatever reason. For example, patients who recur after a liver transplant or have severe autoimmune disease and are on immunosuppressive therapy, either lenvatinib or sorafenib remain reasonable options for these patients. And for patients who get checkpoints in frontline, certainly TKI therapy remains an appropriate second-line therapy. So the treatment regimens are just evolving. So let's fast forward to the future here. So Riyad, I'll turn this over to you, since I know this is something you've worked on for a very long time.
Yeah, Mark, clearly there's been a lot of advancements in the systemic therapy side, and you guys certainly have the advanced patient population handled. We don't want you guys to have a complete monopoly on it, because maybe there's some potential opportunities for local regional therapies to augment the effect in the advanced setting. And this is the launch trial here that was recently published that looked at adding a local therapy in the advanced setting. And you're right, early on in the session, you talked about, if you have a large liver tumor and minimal extrahepatic metastases, maybe there's a rationale here, even though it's advanced, to really deal with the large liver burden, which will be the cause of the patient's demise, probably, as opposed to small extrahepatic metastases. And so this is a 300 plus patient clinical trial that was published, adding chemoembolization to lenvatinib, so a new concept, adding a local therapy in the advanced patient population. And interestingly, this study was positive, with a very impressive hazard ratio, a 57% reduction in risk of death. So OS improved from 11.5 months to nearly 18 months. And the PFS improved from 6.5 months to 10.5 months. So 50+% risk reduction by hazard ratio assessment. So very interesting outcome. The fact that maybe in this patient population, adding a local regional therapy, if properly selected, right? These were large tumors, PVT, the worst of the advanced patient population, probably, but maybe we can augment that outcome by adding a local regional therapy, again, based on the description that you provided early on in this session. Now, also, as you mentioned, with more treatments, with more effective treatments, maybe with more challenging treatments, comes an adverse event profile that's a little bit different. So chemoembolization will be associated with pain and discomfort and nausea, etc. So it's not surprising that the combination group had increased adverse events. That's to be expected. But with that adverse event profile comes a benefit in PFS and a benefit in overall survival. And it's up to us as clinicians to decide whether that benefit is worth that added adverse event profile. And that's something that we think about all of the time. When you think about starting to close off our session for tonight, certainly the HCC patient journey is dynamic and spans all specialties, right? Again, in the last 10 years, with the advent of sorafenib, now medical oncology is an integral part of managing patients with HCC. Most of the practitioners, we have to understand all the tools that we all provide. We have to be knowledgeable and well read on all of these topics. And it is at the multidisciplinary discussion where all of these exchanges and this information is really exchanged and outcomes are optimized. And as I mentioned before, repeating this important point that when we all work together, we will improve outcomes. We will know when to transition from one treatment to the other. We will know when to look at liver functions. We will know about technical feasibility and not. We will learn from each other's successes and failures in clinical trials and real world evidence, etc. So again, I just think that working together with guys like Mark and others is just improves the outcome for that patient, and it allows us to individualize patient care, because at the end of the day, that's really what it's all about. Any closing thoughts, Mark?
No, I totally agree with you. Obviously we've had a number of breakthroughs in systemic therapy for HCC. And, I think with this, it's more and more important that oncologists work with the other members of the HCC team. We definitely want to see patients earlier. We want to make sure that we're able to treat patients before their liver function declines. But when some of these newer regimens came out, I had a good friend of mine who's an interventional radiologist who called me and said, are your systemic therapies getting so good that I don't really have a role anymore? And I said, it's just the opposite. I think as our systemic therapies get better and patients are living longer, there's going to be more and more of a need for local regional approaches to address oligoprogression, critical tumors. And so I view it as just the opposite. I think the partnerships are just beginning. Obviously, it's a very exciting time with all these, intermediate stage trials that are going on that will potentially redefine how we think about intermediate stage HCC. But until then, I think each of these cases should be seen in a multidisciplinary team fashion, and with people working together the way that you and I work with our colleagues at our respective institutions. So, I think today was a great discussion and a lot more to look forward to here.
Yeah, Mark, exciting times. It was great discussion having with you. I think we have some audience Q&A, and I think we can start discussing that a little bit here. Let's take a look at these real quickly and see if there's anything we can handle. So one question is there about the sequential treatment of systemic therapy and LRT in advanced disease. We talked about launch. So that's there. There's a role here. There's a clinical trial. It's mostly Hep B patients in that clinical trial. So we'll have to be careful and cautious to how we interpret that. But certainly there's some data on that. What about SBRT and combining with some of these IOs, Mark? What are your thoughts on that?
Yeah, there's a study from China that showed that the combination of TACE for the intrahepatic portion plus radiation to the portal vein thrombosis provides better overall survival than sorafenib. Now, we're not really using sorafenib anyway in systemic therapy world, but I do think that SBRT is something that does have a role in the management of HCC, and I found it can be helpful, particularly for patients with very, very large tumors that surgery is not an option for whatever reason, or patients with portal vein thrombosis. And I think that in general, SBRT appears to be safe in combination with checkpoint inhibitor therapy. We do tend to hold the BEV. If you're giving atezo-bev, we normally hold the BEV around the time of SBRT, but the atezolizumab could be continued.
What about here's a question that's interesting down at the penultimate question. There talks about patients that are candidates for systemic therapy over LRT in the BCLC-B patient population. Are you happy with that BCLC-B classification to 3 categories now, into sort of the worst ones, maybe the downstaging ones, and the bread and butter intermediates? Are you happy with that? Do you think that needs a bit more refining, or at least it's providing some initial guidance, which I think addresses this question here?
Yeah, I mean, it's something we've hit on repeatedly in this program, is that intermediate stage is incredibly heterogeneous. And, the challenge is we just don't know exactly where those lines are, where patients would benefit more from one approach than the other. And so I think the guidelines are kind of vague, and maybe that's deliberate because we just don't know what to say exactly. What do you think?
Yeah, I mean, I think that they are vague because that's part of the individualized patient decision making, and I think I like, at least it's beginning to recognize that heterogeneity. Frankly, I think advanced is also heterogeneous. I predict a substratification there as well, to be honest with you. But certainly in the intermediate setting, there's no doubt that there are some patients that are just out of the A's and can be downstage to A's and transplants, and those that are just about to become advanced, right? And so there's no doubt that they're basically advanced, as you've mentioned several times, and then everybody else sort of in the middle. My issue is some of these numerical parameters, like up to 7, that try to really categorize good and bad patients. I don't know that we're really there yet without more sort of genomic information, to be honest with you, because I've seen some aggressive looking tumors that have responded well, and some benign 2 centimeter nodules that have progressed extremely rapidly, right? So I think it becomes extremely challenging. There's one question down there that talks about post Y90 regimen recommended for delaying progression. There's no data on this. The only data that exists is, I think, in clinical trial format that is being investigated now. We don't have any data as to what to give Y90 after. But as I mentioned before in the session, we, as part of clinical practice now, will perform Y90 and local regional therapies, and our oncologists here will start patients on systemic therapy because they're so well tolerated, and because we want to, again, accept the cytotoxic effect of the LRT and the cytostatic effect and cytotoxic now, as you mentioned, Mark, effect of the systemic therapy, and really benefit the patient in response, duration of response, and overall survival.
Yeah, I mean, now that we have at least a positive press release with IMbrave 50 with the potential benefit for atezo-bev in the adjuvant setting after surgery, the question is, will we start to extrapolate these data to forms of local regional therapy like Y90? And, I think, again, it would be great to have more data, but it's something that I think many of us will at least consider.
So thank you, everyone, for joining us. Thank you to Mark Yarchoan. It's been a pleasure speaking with you tonight and learning more about HCC and learning about how we can collaborate. Please visit us at PeerView and the website. Complete and submit your post-test and evaluation for credit. You can download all the slides and practical aids, and of course, request a live meeting at your institution. Thank you, everyone, for joining us.